As you know, I'm an orthopedic surgeon, and going through my training, we were taught that the definition of an orthopedic surgeon is someone who is strong as an ox and twice as smart. So, given that, so Dr. Abraham, so being a smart orthopedic surgeon like I am, I've developed some neck and shoulder problems, and it's painful. I come to you because you're not an orthopedic surgeon, and you're probably smarter than an orthopedic surgeon who's twice as smart as an ox. So, how are you going to approach someone like me coming to see you with both neck and shoulder pain? And in 10 words or less, can you tell us how you're going to make a diagnosis of where my pain is coming from?
Okay, so 10 words or less. Thorough history and physical exam with relevant imaging. And I'm going to digress here. There's a couple of key things that I'm looking for. So one is I want to prioritize, are there neurological deficits? So for example, if this is a cervical radiculopathy and you have weakness and you also have shoulder pain, I'm going to prioritize treatment of that weakness because I don't want that neurological deficit to persist. I don't want it to potentially become a permanent problem. Beyond that, I'm going to look at, is one pain source referring to another? So do you have neck pain that's potentially referring to the shoulder? Do you have cervical facet joint pain that's referring to that ipsilateral shoulder region? Do you have a cervical radiculopathy that's doing the same? Or is this potentially a myofascial problem that's causing pain into the upper trap region and mimicking as shoulder pain? Beyond that, whenever we're dealing with patients who have multiple pain generators, we want to be able to prioritize what is the primary pain generator. And that will allow me to focus my treatment in a way that hopefully gives you relief as soon as possible. And finally, I'm looking at function. As a physiatrist, my training very much looks at how do I improve a patient's function, and that's usually one of the first conversations I'll have with patients. So I'll look and see which pain seems to impair your function, which one might be a limiting factor in getting you into rehabilitation, allowing you to participate fully in those sessions. And those key factors will allow me to make my decision. Beyond that, from an interventional point of view, if we're looking at treating multiple different pain structures, I would like to try to utilize less invasive, so less potentially risky injections before moving on to more invasive injections.
Thank you. So, Dr. Beck, my pain's gotten better from my neck and shoulder thanks to Dr. Abraham. But 2 weeks later now, I'm developing pain on the other side with radiating pain down my arm. I'm wondering if this could be from a pinched nerve or is it just some type of mechanical pain? Is there any pearls you can tell us, especially for the therapists out there, that might be able to discern in a very quick way, sort of a test you can do, an exam, something that might make that determination and raise suspicion as to whether this could be some sort of nerve impingement or is this just me being a baby here?
So yeah, there really isn't any one good physical exam finding to diagnose radiculopathy. I did mention in my talk the raised arm test. By raising your arm above your head relieves the traction on the nerve roots and can relieve the symptoms of radiculopathy. But I put a lot more weight in my history from a patient, the distribution of the pain, and then I actually use a lot of peripheral nerve tests to see if provocative tests of the peripheral nerves to see if they could be contributing to pain. So the Tinel sign is a common one by tapping on possible sites of compression of the peripheral nerves to see if that's where their symptoms are stemming from.
Thank you. So Dr. Reitmeyer, aka Dr. Stanwood, turns out it's not nerve pain after all. It is a rotator cuff injury, possibly a rotator cuff tear. And I'm a little concerned because I don't want surgery. Does everyone with a rotator cuff tear need surgery? And how do you determine who does and who doesn't?
So I touched upon a little bit indications for rotator cuff tears. There are partial rotator cuff tears, which often, or majority, don't require surgery. Oftentimes they'll go on to heal on their own or at least become asymptomatic. The full thickness rotator cuff tears, the short answer is most of them will probably need surgery. The smaller tears can sometimes be managed conservatively, and if the symptoms go away and the strength and function returns, it can be a hard argument or hard discussion to have with a patient that you need to have surgery to fix this. The one concern when there is indeed a full thickness tear is, number one, that it won't be able to heal on its own because the fibers are just detached and there's a gap. Number two, there's about a 50% chance that tear can get bigger over time. So those aren't great odds, but over time could be a year, 5 years, 10 years, 20 years. So I have that discussion with patients, and some may say, you know what, the risks are of surgery outweigh the risk of that potential having to deal with it down the road. So short answer is not everybody does have surgery. The general recommendation for a full thickness tear is that you should probably have it fixed at some point. And then there are the large tears in the elderly population that, with a lot of muscle atrophy, the big chronic tears that are more often managed conservatively. Again, when you look at the risk-benefit analysis of whether a surgery would really help them out, what are you gaining? Those can sometimes be managed non-operatively as well.
I plan on taking over for Tom Brady when he retires influence your decision on whether or not you'd operate?
If you had a full thickness rotator cuff tear and you wanted to take Tom Brady's spot, you would probably need to have it fixed.
Okay. Thank you. Thanks for clarifying that. So my rotator cuff is fixed. I'm doing better, and I'm driving my motorcycle with all the vibrations. I get off of that, that neck pain came back, and it turns out it's myelopathy, so I bump into the corner of the wall and fall down and break my wrist. And now I've got a lot of hand numbness with a broken wrist. Dr. Keniston, what is the incidence of carpal tunnel syndrome in wrist fractures, and do you have to do anything different when treating them?
The incidence of carpal tunnel with distal radius fractures reported basically between 5 to 20%. In the community, we don't see it as high as 20%, but in the more urban centers, you see it more because the incidence is increased when the trauma is more severe, basically. So most of the wrist fractures I see are falling injuries. You fall on your wrist. Older ladies, osteoporotic ladies, so it's a low mechanism injury. But if it's a higher mechanism, like a motorcycle crash, a car accident, or anything like that, then your risk of getting carpal tunnel is increased. So in terms of needing surgery for the carpal tunnel with the wrist fracture, there are some hand surgeons that with every wrist fracture that they fix, they open up the carpal tunnel. I don't do that. Because it seems funny if they're not having any numbness or tingling to do an additional procedure on them. So if a patient has a history of numbness and tingling and it's gotten worse with the fracture, I will I recommend surgery on the carpal tunnel as well as the distal radius. If they're not having any numbness and tingling at the time of the wrist fracture, I usually don't do the procedure, or both procedures. I fix the wrist, not the carpal tunnel.
Thank you. Any other questions from the audience for our panel? All right. Well, thank you very much.